Jumbo Espresso Talk Today community. It's Alma Robin here. Aquaba to the Espresso Talk Today podcast show. Welcome to Espresso Talk Today. This week, we have another Excerpts from Experts show. The response to the first, our flagship Excerpts from Experts show last week was so phenomenal, so powerful, and yes, so popular that I understood. You got it, just like I did. These were amazing excerpts from amazing experts in Black health, and they spoke directly to us. Just to recap, last week's excerpts were from Dr. Georges Benjamin from the American Public Health Association, who discussed the importance of public health in Black and Brown communities and achieving health equity. Second, we had Dr. Theopia Jackson from the Association of Black Psychologists, who discussed Black psychology. And this goes much, much deeper and is more culturally relevant than what the APA is following and what they're teaching us. And she also discussed racial trauma, which, again, is something that the APA doesn't even recognize, but we know exists. Then we had Dr. Howard Stevenson from the Racial Empowerment Collaborative, who discussed the importance of racial literacy and managing racial encounters. He also discussed racial socialization. Now, these were not just theoretical concepts. His talk was practical and empowering. Yes, it was indeed definitely a powerful show. And because last week's show was so powerful and popular, and I'm going to say empowering, I decided to make another show with more excerpts from experts. As ETT listeners know, over the past 3 years, many experts have joined us for an uncommon conversation. We had psychologists, public health experts, epidemiologists, medical doctors, an expert in Black psychology, financial advisors, storytellers, and lots of other people who've brought their unique skills, perspectives, and incredible expertise to the show. We've really been honored that they've been so generous with their time and with sharing their experiences with us. We've learned a lot, and I hope that you have too. Now, today's show is special because we have 2 experts gracing our podcast show. To be more precise, we have 2 excerpts from experts on the show. Last week, we had 3 experts, so why this week are we only having 2? Great question. You know I love your questions. And it's because it's what my community wanted. I asked what you thought, and you answered. 3 experts gave us a lot to think about, almost too much to think about in one episode. I don't want to overload you. I don't want to be overloaded, so we decided that 2 experts would be enough. Honestly, when you hear today's experts, just like last week, you're going to agree with me. And don't worry, we will do many more of our excerpts from expert shows. We'll try to have one every month. Believe me, we will have a lot to think about and a lot to discuss. Our experts always bring it. We're going to get to the show in just a minute. I'll just quickly tell you who our 2 experts are for today. Professor Deirdre Cooper Owens, who will discuss medical racism, and Professor William Smith, who will discuss racial battle fatigue. Asante Sana for being in the building today, community. Let's get to it. Let me introduce our first esteemed guest. Deirdre Cooper Owens is a professor in the history of medicine and director of the Humanities in Medicine program at the University of Nebraska-Lincoln. In this position, Dr. Cooper Owens is one of only 2 Black women in the United States running a medical humanities program. Dr. Cooper Owens is also the director of the program in African American history at the Library Company of Philadelphia, which is the country's oldest cultural institution. And Time magazine describes Professor Cooper Owens as one of the country's most, and I say in quotes here, acclaimed experts in United States history. She is steadily working towards making history more accessible and inspiring for us all. Professor Cooper Owens is also the author of the book Medical Bondage: Race, Gender, and the Origins of American Gynecology. This is a fascinating book, and it really opened my eyes to the American medical establishment's biased views and treatment of Black women from slavery all the way up to today. Dr. Cooper Owens examines how the groundless theories of medical researchers and practitioners were accepted and legitimized based on bias rather than on data, and that those theories are still the foundations of medical research and medical treatment, how doctors treat their patients of color today. This is really a disturbing book, I gotta say it, but it's an important book. And for any Black person dealing with the medical establishment, and we know that's all of us. So we have a super historian in the house today, or excerpts from her podcast show with us. And I gotta add here that Professor Cooper Owens is a proud graduate of two historically Black colleges and universities, our HBCUs, Bennett College and Clark Atlanta University. In this excerpt, Professor Deirdre Cooper Owens discusses and defines medical racism and how it shows up in medical research and treatment today. There's a lot to cover, so let's get to it.
So medical racism, if that's a term I've heard, what does that really mean?
Medical racism is like other forms of racism, I think in this country and globally, it's based upon a legacy of power imbalance. It's based upon, and it's not, obviously just doesn't pertain to Black people, because you find distressing statistics around Latinx people, indigenous people, Black people in particular, where the negative medical outcomes are not just based on, kind of these biological deficiencies, but they're based on the ways that clinicians and practitioners treat patients because of their own biases. You tend to see a lot of discriminatory practices. You will even have these kinds of wacky theories about biological differences between Black people and white people.
Yeah.
There's a so-called syndrome called wimpy white boy syndrome, where when white male infants, newborns, are born and they are premature and low weight birth, there's this belief that, just white male children just don't do, newborns don't do as well as other preemies because they're not as strong, right? And the assumption that somehow Black, and this has to born this out, Black female newborns tend to do better. But ultimately, in terms of survival, the white newborn infants tend to survive at higher rates than Black male infants. But often the Black male infants don't get the same level of care.
Yeah.
So it might not even be on this, oftentimes it's not, I think most people who have these biases aren't thinking consciously, I am going to destroy this little newborn, child. But the ways that this country literally socializes how we should treat Black people as different at any age, doesn't matter if you're a newborn or elderly, right? And even the ways our bodies have been treated in death. With the aftermath of slavery, look at the charred remains of the Move children who were bombed and killed in the city of Philadelphia. Like, hey, here, Princeton, here, UPenn, here, Harvard, have their bones and show them and teach them and don't tell their families, right? So it's the ways that different groups, so whether Native folk, Black people, Latinx people, the birth control experiments that happened in Puerto Rico in the 1950s and in the 1940s, 50s in Boston with severely mentally ill people. Medical racism has been a part of the structure of the medical institution from its beginning, because largely the beliefs about biological difference have been so rooted in race, or so-called racial difference, not ever really saying this, but racial difference, that it also becomes a part of knowledge production. So we now see that being enacted, unfortunately, with really bad statistics around maternal morbidity and mortality.
Well, I had an experience with the nurse when I was. She needed to put in what did she do? She needed to put in an IV, and she was having a lot of trouble finding a vein, which for me was very strange because I have great veins. Anyway, she was saying then that I do. No one's ever had a problem until her, and she kept poking and poking around, and she said, "Well, the problem is that Black people have thicker skin." And so she said that what I need to do is I'll put it in the back of your hand, which was actually very painful.
Painful, yes. Yep.
Yeah, and I thought, wait a second, where did she come up with this? That Black people have thicker skin. You know, but on the other hand, then I've also been hearing that, well, Black people don't absorb vitamin D as well, so we need to supplement more.
Yeah.
Now,
Yeah.
if I take extra vitamin D, but am I accepting something that's, racially biased and not true, but not accepting the first one, that we have thicker skin?
Yeah.
Are those different things?
Yeah, and it's a large part of that is about the knowledge that's produced. So if she's been taught this, it's in her books.
Yeah.
Her doctors have shared, when she was in school, doctors, professors have shared this with her, and they're, quote unquote, not making it up, but they're actually pulling it from something that has existed for centuries. Who is she to not believe it? So then when she encounters a patient with, quote unquote, small veins, and I actually have smaller veins, like my mother. So it tends to be harder for people to find the veins. And so I knew when you said the back of the hand, I'm like, yep, I've been there. It's super painful. But I'll even tell them, okay, so this is what you need to do, because I've been through it so many times. Most times they'll listen. But you might run into these people with these antiquated, false ideas that they've learned from a book. And so for me, it's how do you change the thinking? My advocacy work is I help change the curriculum, because nobody needs to have access to those books that are perpetrating these racial fictions, these biological fictions about Black and white people and other human beings. The other thing is, in terms with vitamin D, I often, once again, provide the context. So yes, it's a fact that Black people, and this is the thing, in the United States, because we're not thinking about Black people in Ghana or Panama. It's typically, these studies are Black people in the United States. We tend to suffer from, like you say, a kind of vitamin D deficiency. Why is that? Right? Because I remember a doctor kind of telling me, oh, you might have a vitamin D deficiency. And I said, well, why? Most Black people in the United States live in urban areas. So unlike, now I'm originally from South Carolina, I'm from the Low Country. Most of the year it's sunny, it's almost like the tropics, right? When it's the ocean, we have palmetto trees, all of these kinds of things. But if you're in an urban area that, you get all of the seasons, and it's cold most of the year, but also most of the products that we put in there, many of them already contain SPFs.
SPF.
So you're already putting on sometimes lotions. You're not even aware, your facial creams, they have sunscreen protection, because guess what? White people tend to suffer from skin cancer. So when white people suffer from skin cancer, all of a sudden, all the products are like, it's SPF, 15. You have, SPF protection in your lotion, in your facial cream, in your under eye cream. So here we are buying it and not recognizing that these products are also not going to help us. So it's just kind of a matter of being deeply, hued or melanated, as the young people like to say, that, for me, I don't wear sunscreen anymore.
I don't. No.
And it's helped, because I was living in New York. It was gray, it was dreary. And I realized, oh, okay, I can not wear sunscreen. And I took some vitamins, and literally I felt better. right? So there are certain things we can do. I'm not advocating that people just not wear sunscreen. If you're going to the beach, those kinds of things. But typically, our melanin protects us from the UV rays. And if we just spend 10, 15 minutes outside, we don't even have to worry about it.
Worry about it.
Vitamin D.
Yeah,
Love
but
that.
context of it all. Yeah.
What can we do to minimize? I mean, how do we identify, first of all, and what can we do to minimize the effect of medical racism? Like Robin said, this particular nurse, couldn't find the vein. How are we supposed to respond to something like that?
Yeah, it was interesting. Sometimes you don't know how to respond because you're not even sure, what did I just experience? And you think about it afterwards.
Mhm.
What I found is, being committed to reporting it, so writing a letter, sending an email, reporting it, finding out who you can report it to, just calling, hey, I had an experience. I often tell people about patient advocates or navigators. Many hospitals have them. Insurance companies can provide you with information on how to select a patient advocate or navigator. That's really important because these people can advocate on behalf of you if you don't feel you have the wherewithal or maybe even the knowledge to be able to craft up something that you feel is compelling and will get the point across. If you are aware, because I think we've all had those moments where you're like, wait, is this true? And then it's over and you're questioning, let's say you're aware in that moment, really, where did you get that information that Black people have thicker skin? I like to ask questions, personality. I will sometimes not make a statement. I will just ask a question and we'll have a smile on my face and expect them to answer. Oh, well, I read in a book. And then that's when I say, oh, that's interesting. I'm a historian of medicine and I deal with racial formation theory. Like I'll start just to use a little big terms. And so that's actually not factual. That comes out of 18th century racial science. And now granted, everybody's not a historian of medicine. They can't do that.
Well, how do we know who to trust? I mean,
yeah, it's, what, it is exhaustive. So once again, I do a lot of work helping to create learning modules. I do a lot of talks at hospitals, which are called grand rounds, which is a part of the educational kind of outreach and mission of especially OBGYN departments. I am working with some mainstream organizations to help change the medical curriculum. So, that's one part. There are people who, especially in the schools of public health, they're doing amazing work around medical racism. There's a Black woman OBGYN, Dr. Karen Scott, and also a medical ethnographer named Donna Aine Davis. Her first name is not actually spelled the way it sounds. It's DANA-AIN, Donna Aine Davis. And she and Dr. Scott, they're doing some research around this very issue of medical racism and how people can advocate for themselves. So they've created a kind of template for how do we know what is medical racism that they're using for clinicians and practitioners. I'm working with, it's almost always California and New York, who have actually led the nation in decreasing a lot of these figures, thankfully. But I'm working with the California State Board of Health to create, new measures for dismantling these figures and trying to eradicate medical racism. So for my part, I think the curriculum piece is important. I think for the average patient, though, if you don't feel comfortable, if you don't feel you have the expertise, get a patient advocate or navigator. Get your big mouth relative or friend who you know will not be afraid to ask questions and let the doctor know, oh, I have an advocate on the phone with me. And so they're going to be observing. I don't care if it's your cousin, who you know has the ability to ask those questions that you might be afraid to ask. The other thing is there is an app created by a Black woman called IRTH. It is available on the App Store via iOS, so if you have an Apple phone. And Kimberly Allen Sears has created an app. She's an author, she's a mom, she's a reproductive justice and birthing justice advocate and activist. She's created Earth so that Black and brown women primarily, but I think any woman of color who has experienced medical racism can log in their experiences, and the app acts as a national data tracking system where you are now advocating for yourself. And now there's going to be a repository where it's like, let's say Dr. Jackson at ABC Hospital in the Bronx has a particular history of being, written up. There are complaints about him or her. What you can do, this app allows you to say, so guess what we're going to do? We're going to avoid him or her or they. And it becomes a large part of a database. And and in fact, I just said this to a group of doctors that I spoke with right before I joined you all in this interview. I said, there has to be something punitive.
Yes.
Every other industry has punitive measures for people who are harmful and keep messing up. Doesn't mean it's perfect, but I know if I'm abusing students as a professor, or I write books and it's full of misinformation, guess what? I may eventually lose my job. Even for the cops who, Lord knows it's a problematic industry, but even for the ones where, they're brought to trial and the evidence is just damning. Look at Derek Chauvin, on the anniversary, yesterday was the anniversary of George Floyd's murder.
Right.
He was brought to trial and he was indicted because the evidence was damning. It was one of the few times where we were like, finally, the justice system is working. So even for that industry, there's still some punitive measures where you can lose your pension, you can lose your job, or you might be demoted, or, there might be a settlement or something like that. That doesn't really exist when we think about, the maternal health crisis. Everything tends to be on doulas, midwives, the patients. And I'm saying, what are we trying to do to make sure these people don't have access? So I'm telling hospital administrators and clinicians, y'all are going to have to create some measures to punish these people because they are harmful. They're killing Black people.
They are. This ends the excerpt on medical racism by Professor Deirdre Cooper Owens. First of all, Asante Sana, Professor Cooper Owens, for appearing on the Espresso Talk Today podcast show and for the incredible work that you've been doing for years. Medical racism is real, and as Dr. Cooper Owens said, it's killing Black people. But remember, accountability and advocating for yourself. Bring someone with you, keep notes. And remember, her groundbreaking book, Medical Bondage, Race, Gender, and the Origins of American Gynecology. Dr. Cooper Owens will discuss more about Black patient empowerment in her next excerpt. Don't worry, I'll keep you posted. I now have the honor of introducing our second and final excerpt by the expert today, William A. Smith. Professor Smith is a full professor and department chair in the Department of Education, Culture, and Society at the University of Utah. He also holds a joint appointment in the Ethnic Studies Program, African American Studies Division, as a full professor. He has served as Associate Dean for Diversity, Access, and Equity in the College of Education, and Professor Smith is the co-editor of the book, The Racial Crisis in American Higher Education. His research primarily focuses on racial battle fatigue, which is the cumulative emotional, psychological, physiological, and behavioral effect that racial microaggressions and macroaggressions have on Black people. Dr. Smith's work has appeared in many prestigious journals, too many to name right now. As you can see, we have a real excerpt and a real powerhouse on the show today, and we are grateful for Dr. Smith's willingness to share his and to participate on our humble but uncommon show. So we have a super psychologist in the house today, or excerpts from his podcast show with us. In today's excerpt, Professor William Smith introduces racial battle fatigue. He actually coined the term. He will discuss the symptoms of racial battle fatigue and its impact on Black health. This is really important information, so let's get to it.
I just wanted to get your opinion, Dr. Smith. How would you define racial battle fatigue?
Well, the easiest way to define it is a repetitive stress injury, right? So what that means is it's a biopsychosocial stress response to living in a racist environment that causes premature death, sickness, and a less than ideal lifestyle for infected people. And those are usually the racial minorities in that society. And then within those racial minorities, there is a system that attacks each group independently of each other. And so some of that attack might have more weight in certain domains than it does for other groups. But there are at least four kind of stress responses. There's a constitutional one, there's a social demographic one, there's a psychological one, and then there's a behavioral one. And all those together collectively are how we understand the impact of racial battle fatigue. So when I see you, I can say, well, that's a Black woman, right? And so there's certain things about you that make you who you are, that without you opening your mouth, which you could just be standing there, then you can receive certain types of racial microaggressions based upon how I identify you.
Is that like profiling?
Oh, it's definitely profiling.
Okay.
Right? So, but it's a way to keep people in their place. And that's what racial microaggressions do. They keep people in their place and keep them out of other places where they're not welcome.
Mm-hmm. Mm-hmm. And so
what oh no, you go ahead.
What's an example? I think we're going to ask the same question. What's an example of microaggression? And you mentioned like a micro level one, or is a small thing happening?
So Dr. Chester Pierce was a Harvard psychiatrist and a professor also in the College of Education. And he's the one who gave us the term racial microaggressions. And racial microaggressions initially meant those kind of subtle, mundane experiences that Black people deal with on a daily basis that causes them stress. All right. So it could be, instead of a macroaggression, the microaggressions tend to cause more damage because we have less coping strategies to kind of keep those things at bay, as opposed to those that are macroaggressions. So macroaggressions are those things that are typically at the more community level, group level, institutional level, right? So if something happens like that, we see the Klan march, we have more adapting coping strategies for that, as opposed to somebody making a racist remark towards us, and that causes us kind of psycho-emotional injury.
I mean, like a common thing I've had, being followed around, and one of my favorite makeup stores, I go in there and I'm finding that I'm getting followed around in there. Is that
Exactly. And then they can say, well, no, we're just making sure that if you need anything, we're there. Or if somebody gives a backhanded compliment, all the time. So somebody looks at Marlene and says, oh, you're cute for a Black girl. And all of a sudden you think, what do you mean I'm cute for a Black girl? Right? So they might not realize what they said was a microaggression, but Marlene codes that as a microaggression. And any time a microaggression or someone codes it, then it causes some kind of response. And it could be any of those kind of psychosocial, psycho-emotional responses, right? And even if she didn't code it as a racial microaggression, then her body still will respond to that attack. Because while the mind is a great source to avoid conflict, so it can play games, right? You say, well, that wasn't racist. But your body is a human lie detector. So you can't deny what's going on physiologically. Psychologically, you can play mind games with yourself. But physiologically, your body seeks balance. And any threat against your body is an attack. And racism is a violent act against the Black body.
What do you think, Marlene?
I think that's, I mean, I relate to that completely. But also it reminds me of this time when I was in gymnastics and there was a white girl on the floor and I was doing laps and I brushed past her, maybe barely touched her. The next time I came around, she said to me, African American. And, you know, I know it's a little different than what you're talking about, but I couldn't say anything because I'm like, what am I going to do? She called me an African American, but it was, you know, the way in what she actually wanted to say. It was like, so it just makes me wonder if white people, one, are aware of how strong of a hand, even if they think like the oppression isn't visual, that they have like on our psyches. What do you think about that?
Well, one of scholars that I really respect is Monica T. Williams. She's up in Canada. And what she in her research has shown is that there are some whites who don't realize the microaggressions that they are using against targets of white supremacy. However, those are in the minority. The majority of them will use it to keep you in your place, to make you uncomfortable. And those people tend to be more aggressive. So in one of her studies, she calls it microaggressions are a form of aggression. So these are aggressive tendencies that people understand. I can say something, I can do something that can knock you off of your center and put you back in your place.
Wow, so the emphasis shouldn't be on the micro, but that this is an act of aggression.
Right. And so most people misinterpret micro to think that it means something that's very small, insignificant, tiny, instead of a micro level. Like we understand micro sociology, microeconomics, micro business, micro politics. Nobody would ever say that those are tiny politics. Those are insignificant politics. Those are insignificant money. When they say microeconomics, they understand that it's talking about it at a micro level.
Yeah. Yeah. I mean, when I was just thinking about being followed around in one of my favorite stores, actually, I'm kind of shaking. You know, I'm feeling a bit of trembling, and I'm thinking, is this an example?
Yeah. That's definitely an example. And so another Black woman that's going with you might say, "Oh, girl, that ain't nothing. Don't pay attention to them." But what they don't realize is these things are cumulative, right? Yeah. So it's like what you explained earlier in the pandemic situation. You were talking about an R naught, what we call an R naught, and that's the infectious rate, right? Oh. So what that means is your infection rate 1-to-1 is less than somebody else's who might have a higher number, like a 2. So for every one person, they'll infect 2. So in our society, what is happening is one person can get affected based upon another person's racism, right? And it usually is much bigger than a 1-to-1 type of contamination, right? Because we have linked lives, we know that Black mothers, well, let's start early. Black women who deal with racism as young girls and then young adults will have higher levels of depression as they become older. Now, the linked life part of this is when they have children, when their children are dealing with racial microaggressions, we see a higher impact on depression and mental health condition of those Black mothers between the ages of 40 and 50. So what their children experiences impacts them.
Wow.
So that
Yeah.
shows how we're linked together, and that also speaks to that kind of R0 infection, right? So what we have to realize is that we're linked together as a community. So we should have more unity than disunity. We should be not fighting each other. We should be fighting white supremacy, right? And so we also see the same thing in Black men. So what happens with them is if their children are impacted and their wife becomes impacted, they become impacted. And we don't see the same thing happen to the wife from the husband, right? Because the wife is concerned about the children and the husband is concerned about the wife and the children. So it spreads all the way through.
So, I mean, even if I didn't experience something directly, maybe I saw something or I read an article about there's some racist act that happened on an airplane. I know of a flight that did happen. That could still have an effect on me.
Definitely. And a good example of that is a study that was done recently. And it's kind of following up on this kind of linked lives ideology. For if a Black person who is unarmed and killed by the police in the state in which it occurred, all Black people can expect to have 1 to 3 months of poor mental health days, right? Just for that person being unarmed and Black, the rest of those Black people in that state can expect to have 1 to 3 months of poor mental health days. Now, if a Black person who is unarmed and killed by the police in the state in which it occurred, white people don't have poor mental health.
Oh.
If the Black person is armed and killed by the police, Black people don't have extended poor mental health, nor do whites. So it doesn't work across race, right? So again, if we look at that with the George Floyd situation,
Right.
then the whole Black community can expect 1 to 3 months of poor mental health days. Collectively, that equals 55 million poor mental health days. And if you compare that to the 75 million poor mental health days that all people who are dealing with diabetes have, then you can see the impact that it has on Black people. And that is a conservative estimate.
Wow, that's huge. That is huge. And when you say like poor mental health, you mean depression days, anxiety, insomnia?
Yeah. All that. All that equals up to racial battle fatigue.
Okay.
If you can name your pain, you can develop effective strategies for resistance and resilience. So it's less about it being okay, but racial battle fatigue allows you to say, it's not just me.
Yeah.
I thought it was just, most Black people don't play the race card. They wonder, well, why am I not good enough? Why couldn't I have done better? Why, they think that whiteness is better, right?
Yeah.
And they devalue Blackness, right? Because that's what our society trains us to believe.
Right.
And so when you don't get the mark on that you think you deserve on a test, then you say, man, I'm not smart enough to compete. Something about me and me being Black, I shouldn't be here. And it might be the subjective nature of the professor, right? So when we look at this cumulatively, having racial battle fatigue as a way to put your pain into a definition that you can understand removes the burden and the weight off of your back to say, this ain't about me. This is a systemic issue of white supremacy.
This ends the excerpt on racial battle fatigue by Professor William Smith. First of all, always got to begin with gratitude. Asante Sana, Professor Smith, for appearing on the Espresso Talk Today show and for your amazing work, your amazing research. Microaggressions happen every single day. The threat of microaggressions is felt every day. The symptoms and effects are real. But we're not victims. Black people are not victims, and there are things that we can do to empower ourselves against racial battle fatigue and those microaggressions, the macroaggressions as well. Professor Smith will discuss more about coping mechanisms in another excerpt. I'll keep you posted on that too. Jumbo community, this is where we'll stop the show for today. I hope that you enjoyed hearing these amazing excerpts from truly amazing experts today as much as I did. Weren't they great? It was definitely worth hearing Professor Deirdre Cooper Owens and Professor William Smith again, even if only for a few minutes. But they were powerful moments, weren't they? I chose these excerpts, but I gotta say that it just wasn't easy. How do you choose just one excerpt when you have so many brilliant ones to choose from? And yes, I really wanted to choose them all. But these excerpts that I did choose will give us a lot to think about and to discuss. First, I do want to thank our experts, Deirdre Cooper Owens and William Smith, for meeting with us on the Espresso Talk Today show and for sharing their amazing work. I also want to give them a huge Asante Sana for their incredible and important work that they're doing and have been doing for years. Their work and their research are saving and improving lives. Black and brown communities often are overlooked, ignored, or misunderstood. They're not included for important research studies, therapeutic work, and medical interventions and treatments. Instead, our communities are underfunded, overpoliced, stereotyped, and devalued. But these experts are bringing it and helping Black people and communities. They're improving our physical, mental, and emotional health, and they're on the front lines to stop the trauma of racism and to empower Black people. William Smith has taught us about racial battle fatigue, which he defined as a repetitive stress injury. Microaggressions, macroaggressions, bias, and other acts of racism are stress injuries. The more they happen, the more repetitive they are, and they have physical and mental effects. We can no longer just, quote unquote, ignore it or write it off or push ourselves to stop being so sensitive. Racism is real, and it has real effects on our bodies. Professor Smith explained this in very clear terms, and I hope that we will all heed his advice and take steps to stay healthy. As he said, the body is a great lie detector, so we got to listen to it. Deirdre Cooper Owens explained the history of medical racism in the United States, starting from slavery up to the present day. Yes, medical racism still exists today. Professor Owens ended on that note. It's still happening. As an historian, she provided the context of when and how certain medical practices were allowed, even encouraged, to be used on enslaved Black women. From these practices and beliefs about Black women and Black people in general during slavery and afterwards, the medical community continued certain practices and continued to foster certain beliefs. Black people don't feel pain. White people have control over Black bodies. Black people do not have control over their bodies. These beliefs inject bias and, yes, white supremacy into the doctor-patient relationship. That's a hard thing to think about. White supremacy in with your doctor-patient relationship. And yes, it's jeopardizing Black lives. In fact, Dr. Cooper Owens noted that it's killing Black people today. We didn't get into it today, but in the next excerpts, Dr. Cooper Owens will discuss how we can protect ourselves from medical racism and empower ourselves in the doctor's office. This was powerful, life-saving information here. You don't want to miss that show. I'll keep you posted, don't worry. If these excerpts are leaving you asking for more, and I really, really, really hope that they are, then you can find links to these shows on our Espresso Talk Today website and hear the entire show. No need to wait. Just do it now. And please send your comments and questions to us at team@espressotalktoday.com. And remember, you can always find us on Facebook at the Espresso Talk Today podcast show, your group, and on Instagram at Espresso Talk Today. By the way, and I'm ending here, but this is important to say, we have to read Deirdre Cooper Owens' book called Medical Bondage. It is an insightful and powerful history into the abuses of the American medical system and how Black health, particularly Black women's health, has suffered and continues to suffer today. I highly recommend it, and honestly, I love history, but I wasn't prepared for the range of emotions that arose after reading about the terrible medical experiences of enslaved Black women. It was instructive, though. I believe history is instructive, and I know that this book will open your eyes and empower Black women to take control of our health. You can find more information about this book at the Espresso Talk Today website. Asante Sana for coming through this week and every week, my dear community. I'm Alma Robin at Espresso Talk Today, and remember, now more than ever, strength, soul, and reparations. Ashe.